artificial nose. It does what the nose does as far as trying to recycle our own exhaled heat and moisture. And that's what an HME, that type of humidifier device, does. Recycles the patient's own previously exhaled heat and moisture to turn around and re-deliver it for the next breath. Captures the patient's own exhaled heat and moisture and returns up to 70% of that heat and moisture. Not 100%, doesn't return it all, but returns a good portion of it, about 70% of what was exhaled. I will describe, and my emphasis today talking about HMEs is the passive style, that just to file it for later. There is such a thing as an active HME, where it's active meaning we're actually adding liquid. I was going to grab my bottle of water, but I don't have a bottle of water today. I have the container of water. But where you actively will put water into the HME. I'm not going to talk about that now. That's going to be for another day. I'm going to talk about the fundamental basic passive HME that you guys will encounter. They're not considered filters, even though they may look, when you have one in your hand, going, it looks like a filter to me. Sure, it may look like a filter. It may have some filtering qualities, certain HMEs. Some HMEs do have the HME / filtering capabilities. But don't think that an HME, if you needed a filter, that I'll just grab an HME. No, they make special bacteria filters if we need a filter to filter out particles. So that HMEF, heat moisture exchanger filter, they do have those. Now just a little something here on my diagram, where you will see an HME used is for someone who has a bypassed upper airway, intubated patient, tracheostomy patient, where the HME will be almost directly to the patient's artificial airway. When the patient exhales, the HME captures the patient's own exhaled heat and moisture, or at least about 70% of it. When the next breath is given, that breath goes through the HME. It will pick up the patient's previously exhaled heat and moisture and re-deliver it back to the patient. You can kind of see it pictured here. With a ventilator patient, you have two circuits, an inspiratory limb and an expiratory limb. That's why the two circuits.
Why would you use one of these over some of the other ones?
We'll get to that. We'll get to that in time. Give me just a second. We kind of go over it, and then we'll throw in the whys and benefit, risk, advantage, disadvantage type things. So there's different styles: hygroscopic, hydrophobic, electrostatic, pleated. It, honestly, for us anyways, doesn't matter which style we have, but in case you notice when you start handling some HMEs, and literally we can have 1,000 different HMEs. They are all shaped slightly different. Maybe one manufacturer makes it this color, another manufacturer makes it that color. They all look a little bit different, but still similar. You may see initials, you may see wording on them. Just understand there's all kinds of different types, but they all fundamentally function the same way, capturing a patient's own exhaled heat and moisture to re-deliver it back to the patient. So if you think about this, again, just using my schematic here, so here's the ventilator, inspiratory circuit, expiratory circuit. Patient, they're intubated. When they exhale, the breath that they exhale still goes back to escape, but what is trapped in the HME again is the patient's own exhaled heat moisture. So when they exhale, that heat moisture stays, their volume leaves. When it's time for the next breath coming from the ventilator, delivers the breath, passes through the HME, picks up, again, previously exhaled heat moisture, and re-delivers it back to the patient. Again, what's the other term that we would call this? An artificial nose. It does what the nose basically does for you and I, as far as recycling our own exhaled heat and moisture. HME, so we'll kind of include advantages, disadvantages here a little bit with the next couple of slides. So HMEs can add anywhere from 5 to 90 milliliters of dead space. What does dead space mean to us? Doesn't participate in gas exchange. So another way to think of that is that volume, again, depending on which one we select, however much volume it is, it will not allow that amount of volume to reach the alveoli. We know we have our own anatomical dead space, correct? 1 ml per pound of ideal body weight. I'm just hypothetically. I'm ideal 150 pounds. My tidal volume that I just took in is 500. The volume we say reaches my alveoli, again, 150 minus 500 is 350. That's what reaches my alveoli. But let's just hypothetically say that HME we selected had contained 50 ml of dead space. So instead of 350 reaching my alveoli, now it's only 300, because 50 ml ends up getting stuck or caught in here. It makes it important, especially if we're ventilating patients with smaller volumes. Picture our patients, the smaller the patient, the smaller the volumes, the greater the risk of adding dead space that could create wasted ventilation. So I'm not saying we can't use these in our pediatric patient population, but if we do, we should be very cautious and careful which one we select. If I just have a bin full of different brands, shapes, sizes, HMEs, and I just go grab the first one I find, what if that's the one that has 90 ml of dead space? And my pediatric patient has a tidal volume of 100, right? All the volume is going to be pretty much wasted right there in the HME, not including their own anatomical dead space. So it does matter. It does matter.
Is that specifying each piece, like, is that space or how do you?
Each one, correct. It does. It does. So sometimes, and I know as students, there's so much going on around you when you're in the clinical setting, and somebody may open something from a package and say, "Here, put this on there." And you take, okay, I'm putting it on there, and then you ask, and it's one of these, and you ask the question, I wonder how much dead space is on there. I bet you when they opened it in the package, it was probably a little small package insert that had descriptions of how much dead space that particular HME provides. So sometimes it's like, this is the nerdy me coming out. Hey, can I have that piece of paper? Thanks, I'm gonna look at that. Put it in my pocket, and I'm gonna look at that later when things slow down, and I'll go ahead and put the HME on like you asked me to do. But I'm curious, I want to look at that later to find out. Now, HMEs, this is important to note. HMEs can provide about 70 to 90% of an individual's body humidity. 70 to 90%. Did I say 100? No. An HME is not capable of providing 44 milligrams of water per liter of gas. That is the biggest, in my opinion, personal opinion, there's your biggest disadvantage of the HME. It cannot provide 44 milligrams of water per liter of gas. It could provide about, the good ones, 90%, but not 100. The poorer ones, 70%, but definitely not 100%, not everything that the patient needs, okay? It's why my third bullet point probably works best in the short term. Short-term purposes only. And when I say short-term, maybe it's simply a transport situation. We're going from the ICU, where we're using regular heated humidification, the water, but the patient has to get transported to X-ray, or to the cath lab, or to some other imaging, or dialysis, or something. So, okay, do we load up all those bags and bottles of water and go with us? Or would it be better to put something as simple as this in line? Again, they may be gone for 30 minutes, they may be gone for 3 hours, whatever the case may be. You know, dialysis, they could be there 4 or 5 hours. This is short term, ideally short term. But what you're going to find is there's some places that use these pretty much 24/7 around the clock. But how they get away with using this particular HME for less than 24 hours is by the 24-hour window, guess what they do with it? They take it, they throw it away, and they replace it with a new one. Okay? So we get away with using this type, not the individual one, but an HME for the next 4 weeks on our vent patient, But I thought it was short term. Yeah, well, they kind of get away with it because they can say, well, we didn't use this one for longer than 24 hours. We used it for one day, but we replaced it with another one. And 24 hours from there, we replaced it with another one. And I'll explain in due time why we can do that. But going back to, can I provide all the body humidity we know is optimal? No, I cannot. So I've already, when I select one of these, I've already created a humidity deficit.
Is there a way to add to that?
No. Unless we do regular heated humidification, then at that point, I'm gonna do that and not use this, so. But I gave you just a few different pictures to look at here of these things. They're different shapes, there's different sizes, some are square, some are more oblong. Again, if you look close enough, maybe you can see, okay, God bless you, that's not just a bacteria filter, it is an HME. It does, at least on the ones we can see here, this one doesn't, but I can see it. But it does kind of give us, I think that's the same one, what sort of tidal volume ranges this one could be used with. So anywhere from 150 mLs to 1,000 mLs, that one would be appropriate or acceptable to use. All right, so why? How can we do that? Why can we use this that's not ideal, not optimal? Well, according to the International Organization for Standardization, the ideal HME should do what? Operate at 70% efficiency or better, provide at least 30 milligrams of water per liter. You know, that bugs me, because you know what I said, and what I've said from the beginning, 44 is what our body needs. 44 is what our body needs. But according to the Organization for Standardization, the ideal HME should provide at least 30 milligrams per liter. Already there's a 14 milligram per liter humidity deficit. Use standard connections, have low compliance, add minimal weight, dead space, airflow resistance to a breathing circuit. These things can become clogged with secretion. If the patient has excessive secretions, can become clogged with secretions. Plus, because they absorb moisture, guess what? They can get wet. Another reason why we probably shouldn't leave them in longer than 24 hours, because they will become saturated. I've taken an HME off of a patient's circuit to replace it with another HME, and literally, if I turn it to the side, water is spilling out of it. Patient's own exhaled moisture. And so, if there's that much moisture, the patient's trying to exhale through that HME, again, still exhaling their own tidal volume through it, creates a lot of resistance to gas flow, and it makes it harder for the patient to exhale. If I just left that same HME in indefinitely. But I like this, as many as 50%, half of the HMEs do not provide the recommended humidity of 30. Half of them don't even get to 30. Check manufacturing performance specs and independent bench studies for performance in the range of minute ventilations representative of your patient population before adopting an HME for clinical use. HMEs have a place, but for us to say, yeah, that's going to be enough to provide optimal humidity, you are sadly mistaken. But I will tell you this, if you're going to visit hospitals, and you've already visited some, that this may be the method to provide heat and humidification in that facility. Okay? As things you see the good, you will see the bad and ugly, and learn from that. Learn from that. I'm not going to point to any hospital and say they're doing it wrong, but maybe they could do it better. And again, that's part of what I like to share when talking with you guys and teaching you guys about this stuff, that when it's your turn, when you're there at the table, you can say, well, why don't we do this one differently? Why don't we do this differently? We may see better patient outcomes in the long run because of it. But I know what it's like when you're around that table and they say, well, you know, cost, everything revolves around dollars and cents, right? Cost. These things are very inexpensive. Very inexpensive. The humidifier you want us to bring in is going to cost lots of money on the front end. But if long-term consequences, hey, our patients aren't coming off the ventilator as readily, because of all the thick, picture what's gonna happen to secretions if we don't provide optimal humidity. Secretions get thick, tenacious, now the patient's more prone to get a nosocomial infection and nosocomial pneumonia. Now that patient that we normally, if we did optimal humidity, now the patient's gonna be on the vent for another week. Now, that's costing the hospital money. And so, on the front end, it's easy to say, well, an HME, and I'm just making this number up, but an HME costs $1. The heated humidity you want requires all these extra parts and pieces that all cost more than $1. We're just replacing this HME every 24 hours, only costs us $1 each time we do that. Yeah, that's on the front end, but what about from the back end? Those patients and patient outcomes and shorter length of stays. That stuff does matter. All right, so here's some other drawbacks if you want some drawbacks here. And if you're going to give a breathing treatment to your patient, again, remember the patient population I'm talking about. These are intubated, mechanically ventilated patients. If I'm going to give a breathing treatment to these patients, guess what I have to do with the HME? I have to take it out. I have to take it out. The HME is such an effective filtering type device that the aerosol medication I'm giving, instead of it going to the patient, it goes to the HME. And that's where the medication ends up, inside of the HME, and never gets through to go to the patient. So because I don't want the HME to get the treatment, I want the patient to get the treatment, I have to take the HME out. And I know I've said this already to you guys. Do we like to disconnect things with the vent patient? No. We want to keep that circuit intact and not have to disconnect. And again, there are times we will have to disconnect. There's nothing, we can't get around it. But if this is what we're using, if this is what we're doing with our patient, and let's just hypothetically say, I'm giving this patient a breathing treatment every 4 hours, which is sometimes typical, that means 6 times a day, I'm disconnecting, I'm taking this HME out, reconnecting the circuitry so I can give a breathing treatment. And when the treatment's over, I am now turning the treatment off, disconnecting the circuit again to reinsert the HME. If I'm doing this 6 times, that means 12 times, just because of the breathing treatment and the HME, I have to break and disconnect the circuit 12 times, minimum, throughout the day. Maybe throw in another one when I do replace the HME at the end of the night or end of the day with a new one. Maybe I can multitask. When I take it out for a breathing treatment, I bring the new one and put the new one in. Okay, that'll be today's 24-hour change of the HME. So that's a problem. That's definitely a problem of disconnecting the circuitry. I mentioned this already. Because it absorbs water, it can get clogged, can get blocked just from lots of moisture, creating lots of resistance for the patient to have to breathe through. Again, because it doesn't provide 44 milligrams of water per liter of gas, of course, secretions are going to thicken. Secretions thicken, now there's potential for mucus plugging, there's potential for even mucus to clog up the HME. And now not only is it obstructing the HME, but now there goes your filtering capabilities if the HME becomes blocked. Again, I'm not the biggest fan of a heat and moisture exchanger. So, that's all the negative stuff. Here, you want the positive side?
You sure?
All right. Aside from cost being so less with this as opposed to the other type of humidification, compared with active humidification where you're actively adding moisture, HMEs eliminate the problem of condensation. You will not have condensation in your circuit, period. A lot of respiratory therapists like that. They don't have to worry about water getting stuck or caught in the circuit. No sense of having to disconnect to drain circuits from condensation, and HME will not allow, because I'm not actively adding water, there will not be any issues with condensation in the ventilator circuit. All right, this is I just added this just before class started, and again, I'm not asking you test questions from it, but I wanted to show, speaking of maybe that little piece of paper that comes inside the HME, if it doesn't come in the individual HME, it is going to come in the box that they all come in, kind of the specs about each one, but I just grabbed 2 off the internet that I found and just wanted to share with you. So this one tells me a tidal volume range for this particular one, tells me the resistance to airflow. It does tell me the total dead space, so 43 mLs. It also tells me the moisture output, depending on what volume the patient is moving through there. So you can see this one, 35, 33, 31 milligrams per liter. Also tells me weight. Again, if you think about where these things are located, if the patient has their endotracheal tube, the HME, and then the rest of their ventilator circuit, you don't want this to be too heavy, because it can pull, and if it pulls too much, you worry about maybe it's pulling the tube out. So gives weight, connections, and how many come in a case. This case of 50 was a little over $100, just for price comparison. So pretty inexpensive, about $2 at HME. This one, again, everything looks very similar here, a little bit heavier, so maybe that makes a difference. You can see moisture output, so this one looks a little more efficient than that particular one. Weight, so it's also heavier, more dead space, also heavier. This one, believe it or not, was just under $100, like $99 for a case of this particular one. Again, I'm not asking you those questions on a test, but you can get that information depending on the style, type, brand of HME that your hospital is using. I'm sorry, Chad.
I just said it looked like it come from Temu.
Who knows? Amazon, yeah, Temu, who knows? Who knows where it came from? Some of these particular ones have it. You may notice some of these have like a little port. I wonder what that port's for. You can actually connect some tubing to it to measure carbon dioxide. We'll talk about that technology later, but you can actually measure exhaled carbon dioxide, pulling carbon dioxide from this. Again, if we're trying to measure it. But again, anywhere did you see 44 milligrams of water per liter? No. Because they can't do it. They can't provide everything we need. All right, so I'll quit beating up the HMEs and we'll talk about something different. All right, the heated humidifier. We know from the other day, heat improves the humidification. Heat increases the capacity to carry more moisture to the patient. A heater like this, you can see the temp, at least you can read the number here, at least the temperature setting, normal body temperature. There's a heater here, there's water inside of this chamber, there's my circuitry as the gas will pass over. As I heat it, because of evaporation, it's going to pick up more moisture, but can also pick up 44 milligrams of water per liter of gas. Again, these would definitely be recommended for those with bypassed upper airways, mechanical ventilation patients who are intubated, trached, etc. Because again, it can provide optimal humidity. Drawback, because it's heated, if I overheat, again, that can maybe cause burns in the airway if I was to accidentally overheat. Now, every manufacturer is different. Some may allow the temperature to go higher than 37, but some don't just allow it to go indefinitely high, because there's no reason for us to have a temperature of, say, 50 degrees Celsius or anything like that. But it definitely can go higher than 37. How these things are heated, there's various types and various styles, and it's when we're in our own hospitals that we see the type that we use. Some have a hot plate here, like a little camping stove. Be careful when you're working with it, because again, if you set this to 37 degrees, 98.6 Fahrenheit, and you touch this with your finger, guess what you're going to feel? You're going to feel heat. It is hot, right? It is hot. So be careful, don't lay anything on there, because again, it can burn. Your tubing, oxygen tubing, if it's somehow snaked around here and it's touching, yeah, it will melt. It is hot. There's some that are wraparound, some that have a yoke, immersion heaters, heated wire. We'll talk about some of these, and we don't have examples of all of them. Some are more popular than others. As far as how much moisture these things can provide, depending on the temperature, depending on the length of use, it could evaporate anywhere from like a liter, 1,000 mLs of moisture per day. Well, what happens when it runs dry? Who has to replace the moisture? That's our responsibility. But remember, it may last the entire 24 hours. So on our shift this morning, night shift, it just replaced it 10 minutes before we started our shift. For our shift, 8 hours, 12 hours, we're gonna have plenty of water. It's gonna last. But at some point, maybe on the next shift, toward the end of the next shift, that moisture may run dry. And so it would be something that the RT would have to replace. The water, the sterile water for the humidifier.
Now, since it takes more energy to heat up more water than less water, as the water goes down, will the heater
That's a good question.
kind of...
There's a very specific moisture level that the water has to be kept at. So there will be, and again, it's not shown here, but there will be markings that this is where the water level needs to be kept between. And so that lets us know it's working. It won't, depending on the type, most will not let me overfill, but as soon as the water level runs dry and you see it starting to run out, you know, okay, it's time to add more moisture. And I'll kind of show you what some of these systems look like. Some of these have connections that go to a reservoir system. Some may look like a bag that sometimes folks will stick it up on the IV pole. I don't like that because that's more the nurse's IV pole, and I would hate for him or her to get confused that that's IV fluid as opposed to stuff for my humidifier. But generally there may be a bag that's now automatically filling this. You can see these two pictures have floats. If the water level gets too low, it will manually pull from this automatic feed system. Now there could be potentially, and there's not too many in a hospital type setting, but it could be where you have to physically manually, should have brought a bottle today, pour the water in there, but that's not realistic in a hospital setting. But if we did that, we would have to stop the operation of the ventilator delivering the breath through. We'd have to basically turn everything off for a few minutes while I pour the water in there or add the water into the system. But these automatic systems are what we will see most of the time.
Is the humidifier the same thing as like a vaporizer, or are those two different things?
Different. It's different. It's different. Again, primarily sterile water, but distilled water in a pinch could also potentially be used. But again, given the option, sterile water. Sterile water is what I want to select. Here's a little bit more of a backup view of what we were just seeing here. So that line, again, looks like IV fluid, right? IV solution. Similar style bag, similar style setup, but that's what's automatically filling here. So as the respiratory therapist, we're making sure, yes, the water level is appropriate in here, but I'm also double checking to make sure I have plenty of water here. If I start to see, the water level here is okay, but I see this bag has almost bone dry. There's just a drop or two of water left. That may be a good time. Go ahead and, with everything else you have going on today, go ahead and grab another one of these and replace it so you don't have to worry about it. Like I said, it takes a day to evaporate about 1 liter, 1,000 ml. So it's not something you're doing for yourself personally every single shift, but it will happen. It will happen. And you don't want to be known as the therapist that every time I take over for you, what do I have to do? Every one of your humidifiers, those automatic feed bags are bone dry, and I got to replace every single one of them because that's something you always forget to do for me. Do you think that's how you start a reputation, and that's not a good one?
No.
That everybody's going to have to make up for your deficiencies as the team, and there'll be times, the water level's pretty low. I know it's not going to last too much longer, but because I want to be a good RT to the next RT that's coming on board my shift, I'll bring one of those bags, I'll leave it in the room. And during a report, I'll say, oh, your humidifier still has a little bit of water left, but I brought you a new bag. So it's there. So that therapist doesn't have to go looking for one and go find one. I've already brought it back. I just didn't connect it because there was still some water left in here. But on your shift, you're probably going to have to replace it. That's fine. It doesn't take me a few seconds to replace that. But it does take time if I have to go to the department or go to the equipment room or supply room, get that and bring it back. And you should have told me that in the first place. There's times, darn it, sorry, things were so hectic last night. I meant to bring a bag, but I forgot. But I'm letting you know now. Hey, when you go up there, you don't want to grab a bag, so you don't have to, make those extra steps. just some different styles. This is the wraparound style heater. This is what it looks like. This is kind of a schematic of the item. There is a water reservoir here that the sterile water is inside, and I wish I could have one of these where it's pulled out. It's this thing that's sitting down in. Notice there's a wick in there, but what's in red represents the heater. So again, you set the temperature to whatever you want the temperature to be, 37, to make sure you're able to pull the 44 milligrams of water. And this system will automatically feed the water that's inside this column. Now, when this starts to run dry, same concept as that bag, that needs to be replaced. All right, so humidifiers should provide optimal levels of humidity in inspired gases. Our current AARC clinical practice guideline recommends setting our heaters to 34 to 41 degrees Celsius at the circuit Y with a minimum of 30 milligrams per liter. That's what our own guidelines say. So when you say, well, how can they make an HME that only provides 30? The guidelines say. Unless the guidelines change, then they would have to change. So that's what our guidelines currently state. However, we've talked about it since we started, optimal humidity, what the body needs, is 44 milligrams per liter of gas at 37 degrees Celsius. There should be no debate on where a humidifier, heated humidifier, should be set at. And so I hope I've expressed my wishes to you when the time does come that you're providing heated humidification for an intubated patient on the ventilator. Again, because we know if we don't, what's going to happen to the mucociliary transport system? That water layer is going to start drying up because the body's going to try to make up for the deficiency here. Water layer dries up, secretions thicken, cilia stop working or stop working as efficiently as it should, and all kinds of problems from there. All right, any questions? Any issues? Okay. So, talking about that heated humidification where the water is being added. Now, what's the drawback? Condensation. Loose, free water inside of the circuitry from condensation poses a risk, obviously, to the patient and us, because at some point, what am I going to have to do with that water? I'm going to have to drain it. I'm going to have to empty it. And do you think, especially the first or second time you're doing this, again, what's inside the circuitry from a ventilator is positive pressure. What do you think happens? Picture there's water in my circuit. What happens when I disconnect? Because of pressure, where does that water go? Splashes up. And again, whenever you disconnect the circuit, don't do one of these, right? Don't do it at your face. You know, I'm going to point it to Jeremy. You know, I'm going to point it somewhere else, but not my own face. So yeah, obviously don't point it to another member. Don't point it at the patient. You know, maybe point it down. Maybe slide a trash can over so you know, okay, that's where the water is going to go. But be mindful of that spray. Again, even if there's just a little bit of moisture inside that circuitry, in that circuit, there's pressure under there. There's positive pressure. It's going to start shooting that liquid out, even small quantities of it. So condensation can waste a lot of water. If we don't drain the circuit and it builds up, it can occlude the circuit, can block the circuit, not allowing the breath to go back and forth through. Again, that material could be aspirated by the patient. If that, where the circuit is, gets close to the patient's own airway, again, they can aspirate that. We know it can colonize bacteria, because we know bacteria love what? Warm, moist environments, and this definitely is both of those. We can try to minimize problems by using water traps in line. Okay, we'll catch the condensation, but at some point, we need to do what with those water traps? We need to drain the water trap. And so, again, that's more potential splashing and things like that coming our way. Positioning circuits so it drains condensate away from the patient. So, again, picture the ventilators here, patients in bed here, circuits going down toward the patient. If there's any moisture in the circuit, because of gravity, it's going to drain that way. if I just come into the room and say, circuit, I didn't notice the condensation, and I lift up the circuit so I can walk under it, well, if there's water in the circuit, where's it gonna go? Well, depending where the water was, some of it may drain that way, but some of it may drain this way toward the patient. So, positioning of the circuitry so it doesn't, if it collects, it doesn't drain toward the patient. I don't wanna drown the patient, right? And of course, even though it may be clear water, sterile water, still, I gotta treat it as though it's contaminated. And being very careful, obviously, not letting it get on me or anything like that, or in my mouth or in my eyes. You know me, I'm talking during everything, blah, 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 yuck. You know, now it's in my eyes, my contact, I wear contacts in my contacts, in my mouth, because I kept talking, you know, all that stuff. So always be very, very cautious and careful. All right, there's some condensation for you. Okay, you can see it collecting on the end. This is the inside of the circuit. You can see it collecting on the inside of the circuit, but look here. Now I got some free running water. You know, it's, again, as it builds up saturation inside the circuit, it starts to, we'll use the term rain out inside the circuit, but that's condensation. Again, I said we could use potentially water traps here. So if there is condensation here, maybe it gets trapped here in the water trap. But at some point, as the water level rises in the trap, and I don't change it, I don't empty it, what's it going to do? It's eventually going to spill and start to spill into my circuitry.
Is that better, right? Because it's not gonna create any resistance in the circuit for the patient.
Correct,
and
correct,
make it tight.
correct. So having water traps will be nice because it can collect the condensate. And again, part of my duty and responsibility as I'm managing this patient is to make sure I'm draining any condensation away from the water trap, keeping it out of the circuit. All right, quick history lesson here. Okay, quick history lesson here. I know you guys are all excited about history. Talking about where we came from and why things are the way they are now, even still to this day. So when you have a humidifier and you heat the temperature, what happens to evaporation? It increases. So we can carry more moisture, right? If I heat the humidifier to 37 degrees, I know it's picking up how much moisture? 44 milligrams of water per liter of gas. And so now that saturated gas starts to travel through my circuit to the patient. Talked about this the other day. Connor, you asked a good question about it. As the gas moves through the circuit, moving further and further away from the heater, what happens to the temperature? It cools. And so the temperature, instead of being 37 degrees, as it starts to leave, it starts to go down, 36, 35, 34, as the gas moves through the circuitry. What happens to the moisture that was collected, that molecular water, starts to rain out inside the circuitry, hence condensation. So by the time the gas reaches the patient, are we still carrying 44? No, we're carrying much less. So, history says this is what we would do. To deliver 44 milligrams of water to the patient, we would have to do this. Heat it to 50 degrees, and it would carry 84 milligrams of water per liter of gas. That's what it would pick up here. Knowing the temperature is going to do what? Cool and drop. Okay, so when the temperature cools and it drops, that 84 number starts to dramatically decrease. But the good news is by the time it would get to the patient, it went from 84 to 44, what the patient needed. But what happened to the 40 milligrams of water? All collects in the circuit as condensation. And so the water trap example is what we could use, but that's a lot of water. That is a lot of water. And so therapists had to make some choices, okay? Either we leave it like this, and about every 30 minutes, I'm having to run into my patient's rooms and drain this condensate before the patient would drown. Or, what if we turn the temperature down so there wasn't as much water? Am I delivering 44 anymore? No, I'm not. But I'm lessening the amount of condensation. We would lower the temperature to the point It was around, I can't even remember the temp, but it was low enough where what eventually would reach the patient was only about 30 milligrams of water per liter. We would turn we still have some condensation and we still have to drain it, but I wouldn't have to rush into that room every 30 minutes afraid my patient was going to drown. Less condensation was forming. But ultimately, by lowering that temperature, we would only deliver approximately, and every place was a little bit different. Some could be even less, some could be a little more. But it was generally around 30 milligrams of water per liter is what was delivered to the patient. Talking 1980s. Some company out there came up with, we have this new thing. We call it an HME, and it will eliminate your condensation problem. Great, from the RT's perspective, great, fantastic. I don't have to rush into that patient's room so frequently anymore to empty that condensate. And guess what? Moisture level still was providing what we were giving at that time. So we didn't notice any difference as far as patients' secretions being overly thickened or anything like that. They were compared to how we do it today, but at the time we were like, great, we can eliminate all of this stuff. The water, the heater, the whole setup, the use of electricity, all those costs that would increase, to replace it with a 25-cent HME that, hey, you can't leave it on all the time, 24 hours is tops. Okay, great, 24 hours later, we'll throw that one away, we'll put a new one on. And so that's where the HME took off, and why we still use HMEs sometimes a little too much today. But what we know now, providing optimal humidity, we take this type of setup and we've done some modifications to it today. So we can deliver 44 milligrams of water per liter of gas, 100% saturated at normal body temperature by the time it reaches the patient. And it's by adding a heated wire circuit. Heated wire circuit. So the setup is really the same as we saw in that older picture, where we would have to heat it up to 50 degrees. Heated wire circuit, I still set it to 37. At 37 degrees, it's still going to pick up 44 milligrams here. Kind of zoomed in here. I don't know if you can really see the inside of the circuitry, but there's wires running inside the circuit. What that does, the wires maintains the temperature to what we have set here. So there is no cooling of the gas as it moves through the circuit. Now you can see on my picture, at some point, there's no more wire, the gas will cool between here and the time it reaches the patient. If this was my patient, I would take out this little extension piece and lessen that amount. But nevertheless, I'm not going to have the condensation because I'm not allowing the gas to cool. There's a temperature probe here. It's supposed to be close to the patient's airway, and there's a temperature probe right here to monitor the temperatures at both locations. I set the temperature here. That's what the temperature should be reading here as well as here. And if it doesn't, it alarms and lets me know. But heated wire circuit, $1 million idea that I didn't come up with. Granted, I was too young to come up with that idea way back when. But that's what you see a lot of today, a heated wire circuit. There's even some fancier ones. They're not as out there yet. I could just imagine it's a matter of time, where this corrugated tubing has its own kind of, the corrugation has a heater with it. But that's what you will see right now is the heated wire. Again, heated wire circuit. And so if you want my opinion on what's optimal, that system. Why not that system? I don't have to worry about the condensation issue anymore, like normal heated humidification used to be. I don't have to worry about having water traps on here. Again, as long as the temperature is maintained, it's still going to carry 40, and I have the temperature at 37 degrees, it's still going to carry 44 milligrams, at least to the point of the end of the wire. And again, hopefully there's not a great deal of distance between this location and getting inside the patient's airway. So why don't we provide optimal humidity with heated humidification? That's an example of a heated Passover humidifier. Jeremy, do you have a quick-
No, I was just saying, like, it's just the money thing, probably with the.
Sure. Add up all the parts and pieces And again, without knowing what the dollar figures are, you can only envision. All right, for this patient, again, think you're the boss upstairs that never sees patients, but you're sitting behind a desk somewhere making decisions based strictly on numbers, right? Well, let me tell you, these circuits are more expensive than the non-heated wire. So now every vent patient's gonna have to have this much more expensive circuit. You're gonna have to buy all these bags of water. You're gonna have to buy this heater and humidifier that's gonna run on electricity, so the electric bill is gonna be higher because of it. This whole setup is gonna cost much more than a single HME. But think about the effectiveness of your patient, right? And what care you're providing your patient. Again, and I'm only talking about the mucociliary transport system being able to stay intact by using optimal humidity and not just the HME. That, again, second you grab that HME, humidity deficit already, even the best ones, already there's a humidity deficit there. All right, any other questions about humidity before I move on? Yes, Grace.
HME, that is the first thing. That is, this kind of thing is kind of active humidity.
This is active humidification.
But, HME.
Standard HME is passive. It recycles the patient's own exhaled heat moisture, as opposed to actively adding heat and moisture with a system like this. All right, so when I ask the question, you have an intubated, mechanically ventilated patient, which type of humidifier would you select? And I put HME as an answer option. I will come behind you during the test and slap you across the back of the head because that's not the right answer. Looking at you, Chad. Chad was side-eyeing me there. Because you know an HME can't provide 44, but a heated humidifier, heated pass-over humidifier, because again the gas does pass, right? Pass over, heating it increases evaporation, you can carry 44. So when I ask that question, intubated patient on a ventilator, what's the ideal humidifier? Don't pick an HME. Bubble humidifier doesn't work with this. That's the nasal cannula, right? But and it's not heated. Exactly, it's not heated either. But a heated humidifier or a heated passover humidifier, still the same thing. But I'm looking for humidifier and I'm looking for heated. That's actively adding heat and moisture to the patient's inspired gases. Okay. Switch gears just a little bit and talk about bland aerosol therapy. All right, bland aerosol therapy consists of liquid particles suspended in a gas, not molecular vapor or molecular water. These are liquid particles suspended in a gas. And I guess the easiest way to differentiate, you can see this. You can see an aerosol. You can't see the humidified particles. Humidified particles are way too small. You can see this. Now there may be some times, and I'll try to demonstrate it in a lab, at least for my group, and I'll remind Desmond to do it for his. Sometimes if the flow going through the device is so high, sometimes it is hard to see it. And sometimes if I hold it up against a white wall, it's hard to see it. But if I hold it up against a darker background and I slow the flow down, you might be able to see it better. And so remind us Friday, in case I forget to mention it, hey, for bland aerosol, I want to see it. I want to see that aerosol. Like John, you said we should be able to visually see it. As opposed to a humidifier that's running, you can't see the humidified particles. So, involves the delivery of sterile water. Hypotonic, isotonic, hypertonic salines could also be used for an aerosol. These, some, not all, but some can also be accompanied by oxygen therapy. So some of you guys may have had discussions with Desmond about some of our O2 devices, and he may have mentioned some of these already, but using them for oxygen therapy. We have a whole chapter to talk about oxygen therapy and all the if, whens, and whys later. This, I'm just talking about the bland aerosol that this device can provide. So I'm not going to talk too much about the oxygen part of it. I'm talking about just simply the bland aerosol part of it. So, the equipment needed to deliver a bland aerosol includes an aerosol generator of some sort and a delivery system or an interface. The aerosol generators that this chapter at least mentioned was a large volume jet nebulizer and an ultrasonic nebulizer, and we'll talk about different ones. Delivery systems can include, again, the chapter's words here, an airway appliance. I'll sometimes use the word interface. All those are fancy ways to basically say the mask or the thing that you're going to attach to the patient's face with, right? That's the appliance, or even an enclosure. We'll talk about some enclosures here at the end. All right, so large volume jet nebulizer is the most common device to deliver bland aerosols. Some of you guys may have seen this in the lab, kind of set up in the lab, or Desmond may have went over some of this with you guys in the past. It is pneumatically powered. When you hear that word pneumatically powered, what does that mean to you? Or you might not even know it yet. It's okay if you don't. Pneumatically powered. What powers this? What makes this run? Is it going to be plugged into electricity? No, it's going to be plugged into something else. This part's going to be connected to your flow meter, right? Your flow meter. And so it's the compressed gas source that powers this thing. Pneumatically powered. The gas source. Now I can plug this into oxygen. I can even plug it into air. If oxygen percentages is not important to my patient, just the delivery of bland aerosol. So I could run this on any gas, but I need the gas source, the pneumatically powered. So again, picture, this will be connected to a flow meter. The flow meter is plugged into the wall outlet. That's pneumatic. That's the gas source. These, the ones that are unheated provide anywhere from 26 to 35 milligrams of water. Heated ones can go anywhere from 33 to 55 milligrams of water. Again, I don't classify these under the term humidifier, but they can provide moisture, obviously, because there is going to be moisture in here. They can provide moisture. They can be heated different ways. Again, depends on your hospital and what type they have. A base one that heats, a wraparound that heats, an immersion one where there's really just a heating element that goes inside the water to moisturize it, and one up here at the top, the yolk. Now I do have an example here, at least pictured, of the yolk. This is your jet nebulizer. I've unscrewed it from the container, and I've simply added this piece in between. So this is the top portion, there's the bottom portion. I'm going to bounce back pictures. Top portion, bottom portion, all I've done was add this piece in between. This is the yoke style heater. And so I can heat this. And heating it is going to increase the evaporation and provide more moisture to my patient. But it's the exact same thing that was pictured previously, just with the addition of a heater. And this is the style you probably encounter most often in a hospital setting, if they choose to heat it. All right, so how they work. The liquid particles, this is kind of the opposite direction from, say, a bubble humidifier, where the gas goes down and bubbles out. This one, it actually pulls the moisture up. Pulls the moisture up. Gets right here to the jet orifice. It's at that point, it smashes into that jet orifice and creates its aerosolized particle. Makes the particles smaller, obviously, but it's going to be aerosolized where we can actually see it. And then that bland now aerosol then can be delivered to my patient. Again, not getting too much into the oxygen part because we have a whole chapter on that later, but there's also some variable entrainment ports here where you can set a very specific FiO2. All right, so what are those interfaces or appliances that could be used with this type of bland aerosol? Aerosol mask, face tent, T-tube or T-piece, and tracheostomy mask. But all of these will need to be connected to large bore corrugated tubing. Large bore corrugated tubing. Not the single or small bore like oxygen tubing, like your nasal cannula tubing. So it does require that corrugated tubing. I do have to be careful because again, it is still liquid. It's an aerosol, but it's still liquid. I can still get condensation in my circuitry, especially when I heat it. But even if I'm not heating it, condensation still could collect in that circuitry. As far as the interfaces, make sure you're comfortable with being able to identify them. I know Desmond will quiz you guys, or you're supposed to put things together maybe, perhaps. I'll have all this stuff still set up on Friday to make sure you're comfortable with it and can identify it. Aerosol mask on your far left, face tent there in the middle, tracheostomy collar here. But notice, again, harder to see this one, large bore corrugated tubing. That's going to be connected to your large volume nebulizer. Again, depending on what the patient has, could determine which one I choose. So looking at it, you guys, if I needed to set you up on bland aerosol, based on the interfaces, the appliances that I know we have, the best one for you guys would be a simple aerosol mask. But you came into the hospital and somebody busted your nose. Your nose is swollen, it's painful, and I come in, I'm going to put this right in your, ow, do not touch the damn nose, that hurts. We can try the face tent. All right? Not directly touching the nose. If you have a tracheostomy, I think pretty clear, we could use a trach. The fourth one is the T-piece or T-tube. If the patient has an endotracheal tube and they don't need the ventilator at that moment in time, we can use the T-piece or T-tube. So this will be connected directly to the endotracheal tube, still large bore corrugated tubing with some reservoir, 6-inch reservoir tubing. We'll look at that more this Friday. This lady has a tracheostomy tube. So this could work for a tracheostomy tube. I'm going to bounce back a slide. This guy had a tracheostomy tube. Does it matter? Does it really matter which one I select if a patient has a tracheostomy tube? Well, I will say this one that is connected directly to the tracheostomy tube, we better be careful with this tubing. If I trip over this tubing or I pull this tubing too much, what's it doing? It's pulling on her trach. This one, if I pull on the tubing, it's pulling on the mask. It's not directly connected to the tracheostomy tube. So weigh your options there, which one you think would be best for most patients or your patient in the situation you're in. Now, if you notice her, can you tell what's right here? That closed suction catheter. So maybe she requires frequent suctioning. The previous guy didn't require frequent suctioning, but for her, because they're always having to go down and suction her, this is the route they chose. Again, being careful, because this is still going to pull on the tracheostomy tube, so make sure there's plenty of slack and space and nobody's going to trip over it, or she's not going to accidentally cause this circuit to pull too hard on her tracheostomy. All four of these, the setup is exactly the same. Sometimes students make a bigger deal. Hey, John, I can set up an aerosol mask setup, but the face tent, I'm not too sure about. It's the exact same system. The only thing that's different is the interface. That's the only thing, but the rest of the setup is exactly the same. So when we talk about this, we're really talking about 4 different setups, but it's just 4 different masks or interfaces. The rest of it is exactly the same. And I say that because I remember when I was a new RT. And in school, we talked about this. We didn't have the cool lab like you guys do, so again, things were not necessarily as we see them today. And I knew how to set up, say, an aerosol or a T-piece setup, or even the trach setup, but I never set up a face tent before. And I remember I had one of my patients, order came across to set up a face tent. And I'm like, never set one of those up before, not even in school. I'm not sure, I don't even know what I need. And so one of the nice RTs that was there, I asked her for some help. I'll never forget her to this day. She was so sweet and so nice and did not make me feel dumb or stupid. As she went to the, I followed her to the equipment room. And she said, well, here, let me show you what you need. And she started pulling stuff out. And I'm like, that's it? I could have, in my mind, I'm saying I could have done it. I thanked her so much for helping me out. I'm like, okay, I got it, no problem. I got it from here. And, I grabbed the stuff and went up and set the patient up. And it dawned on me at that moment in time, oh, it's the same damn system, right? But at the time, I'm thinking those are 4 different things, and I haven't set them all up yet. All I needed to do was add the mask as opposed to the face tent as opposed to the aerosol mask. That was the only thing different about that particular situation or setup. Additionally, with that setup, because of the potential for condensation, there needs to be some sort of water trap or water drainage bag. Now, this one is very similar to the one I showed you pictured with the ventilator patient, and it would be necessary, that style, for the ventilator patient. One like this would not be appropriate for the ventilator patient. Again, if this was connected to the ventilator, again, the ventilator is providing positive pressure, and this is just a bag, a plastic bag. What do you think would happen to this bag? It would start to expand and inflate. This is hard plastic. This would not pop or break. This one would. But if we're using some sort of bland aerosol, I still need some sort of drainage as a water trap. Something like this, I would simply unscrew it, dump the contents into the trash can or down the sink, reinsert. This one, there's a stopper here I can pull out, slide the trash can over, pop it out, and literally, sorry for my example here, it will literally pee out into the waste receptacle, and then close it back up. Again, don't let it get too full, because then there's potential. You get busy, you get distracted for the next 4 hours, and you were close to filling this, and now it's starting to spill into your circuit. So my just personal thought of, if it's around half full, and you have the time, go ahead and just empty it, and you don't have to worry about it the rest of your shift. But don't forget, not only do you need the large volume nebulizer connected to the flow meter, corrugated tubing, the large bore corrugated tubing, some sort of water trap or drainage bag, and then the interface, whatever, in this picture it's the aerosol mask, but whatever interface you need. Questions? Okay. Some things that we will be looking at. So pictured on the left, what would I call this? Large volume jet nebulizer. Large volume jet nebulizer. That's going to be connected to the flow meter. Large bore corrugated tubing, going to a drainage bag, going to the mask or interface for my patient. Anybody have a clue what's pictured here? This is a bubble humidifier. A reusable, non-disposable bubble humidifier. Notice what looks, aside from just the color of things, still connected to a flow meter, but what will I connect here? My oxygen tubing or cannula tubing. There's nowhere I can connect large bore corrugated tubing, and vice versa. If all I had was small bore oxygen tubing, I can't connect it here. That's one nice thing in what we do. Things, honestly, really dummy proof. You can only put them certain ways. Now, granted, we will see creative ways that are completely 100% wrong, but they fit, they work. But bubble humidifier, large volume jet nebulizer. So this would be connected to your nasal cannula. All right, ultrasonic nebulizers. Now you don't see the ultrasonic nebs as described in the chapter the same way you used to. There's still ultrasonic nebulizers that are out there. They still all work on the same principle. We'll get to how those things work a little bit down the road. But an ultrasonic nebulizer is electrically powered. So don't confuse this with the large volume nebulizer that was pneumatically powered. This one is electrically powered. So this must be plugged into electricity. So you do need an electrical source for this to work. Uses a piezoelectric crystal to generate an aerosol. I'll show you what it looks like in just a second. Okay? Uses a piezoelectric crystal that vibrates at an extremely high frequency to generate an aerosol. Ultrasonic nebulizers, as described in this chapter, this particular type, strictly used for sputum induction. Strictly used for sputum induction, and to initiate a cough so the patient can expectorate. You know, we need that sputum specimen, that sample, and I walk into the patient's room, okay buddy, can you cough and expectorate into this specimen cup? And they give me a good strong effort, but there's nothing there, and I know, well, I got some options here, right? I can get that suction catheter, that Lucan's trap, and go down and try to get a sample. Okay, and the patient does not like that, and I don't blame them. I wouldn't like it either, especially if the patient's awake and alert and not comatose. But maybe I can give them an ultrasonic that kind of stimulates, gets secretions hydrated, where now it leads to easier for the patient to bring up an expectorated sputum sample on their own and doesn't require me to stick that suction catheter down their airway. Just another option.
Is that what they call cuff assistant device?
That's different. That's different.
Okay.
That's different. That cough assist device is to assist the patient in coughing and bringing up mucus, but not so much. We don't consider that a sputum induction. Sputum induction, we're doing something to actively cause them to bring up mucus so we can take a specimen from it. Now, some of the stuff we'll talk about associated with what you just described, we can incorporate into sputum induction to kind of assist and help them. All right, so the piezoelectric crystal, that's always my favorite part of this. All right, it's here. We're looking at an ultrasonic nebulizer. It's down here. Creates vibrational energy, electrical energy that causes this to vibrate at extremely high frequencies. The frequency goes through a water chamber. The vibrational energy goes through a water chamber, and yes, that is tap water. But again, I need it to help vibrate that vibrational energy into the medication cup. Now, the tap water and the medication, liquid medications in here, do not come in contact together. That vibrational energy goes through the water, then stimulates the bottom of that nebulizer cup to create an aerosol. I'm not going to ask you to label all the parts and pieces, but I would say that term, piezoelectric crystal, wink, wink, hint, hint. I remember that name. All right. Enclosures could also be used to deliver bland aerosol therapy, especially to infants and to small children who cannot tolerate wearing masks. Again, think about a 4-year-old, 5-year-old. Here, you just have to wear this mask. No, I don't. And then, oh, you say, no, I don't. It's why you may see in time, especially in the children's hospital, a lot of the masks may have like a dragon or a frog or an alligator or something, so it can kind of be in character, if you will. Well, hey, whatever it takes so they can keep the same mask on their face, right? But these type of things have been around forever. 40, probably now going on 50 years. We used to call them croup tents. You don't really see those used much anymore, but the chapter does describe it. So this aerosol does promote vasoconstriction. So vasoconstriction means the blood vessels will narrow, which lessens edema, lessens swelling, and would reduce an airway obstruction. So if they have some sort of upper respiratory, I'm going to use the term infection, but it could just be upper airway inflammation. Again, blood vessels are dilating. There's lots of edema inside their airway. If we listen to a breath sound up here, we may hear, what's that thing called? Stridor that we can hear. By giving them something like this bland aerosol in an enclosure, could help vasoconstrict, which lessens the amount of edema and helps to keep the airway a little bit more open. Problems with enclosures, though, is it can get hot in there. Issues about, well, where's the exhaled carbon dioxide going to go in an enclosure? So those are also issues. And probably part of the reason you don't see a lot of enclosures used so much anymore. It just depends. It just depends on the situation. So this is an oxygen hood enclosure, a hood type of enclosure. So you can, I know it may be hard to see from the back, but here's the baby. This enclosure, notice the large bore corrugated tubing. That's where my aerosol is coming from. Maybe I should add this to the fifth appliance for the bland aerosol, the jet nebulizer type system, but this enclosure. Kind of close up. So what it's creating around the baby's head, aside from the bland aerosol, but if we're using it for oxygen therapy and oxygen-enriched environment, again, not a mask or cannula directly on the child's face, if they're more likely to pull it off. And again, you can tell the age of this child that they're not going to be able to follow our instructions when we say don't pull that off or leave that on. I know we haven't talked about them yet, but what's measuring up here, there's an oxygen analyzer. So if I have the device set to say 30% oxygen, and if I was to do a 30%, I want to still make sure that that's what's being delivered. And so there'll be an oxygen analyzer in here, and it's measuring the oxygen environment. What's that oxygen concentration? These are the tents. Again, you don't see tents used much anymore, hence the black and white picture there on the left. But these were part of the enclosure system, again, ways to deliver a bland aerosol. All right, so problems with any sort of bland aerosol therapy, and I guess the first one could be true for any type of therapy regardless. Cross-contamination, infection. And so make sure we're making the appropriate infection control policies and following the guidelines there. Environmental exposure, again, secondhand exposure, which could mean secondhand exposure to other patients in the vicinity, even to us. You know, if we're delivering aerosol, we're in the room, we could be taking some of that aerosol in ourselves. So depending on what we're delivering, you know, could it cause some negative effects to us? If there's inadequate aerosol output, make sure it's turned on. I mean, I know that sounds silly and obvious, but number one, make sure you turned it on, right? You have turned it on, still nothing's coming out. Make sure the bland aerosol, the liquid that was supposed to be in there, is still in there, that it hasn't run out, because if it runs out, even though it's turned on, it's not going to produce an aerosol. Overhydration, that's especially true with the ultrasonic nebulizers. Ultrasonic nebs put out so much fluid that secretions could suddenly swell. Again, now they're more liquefied, they should be able to bring those up a lot easier, hence why we use them for sputum induction. But sometimes that can create a problem. Again, all this extra fluid, for you and I don't think it would be a problem other than us recognizing, hey, at some point I'm really going to need a bucket or something to expectorate into because all my secretions are really liquefying. But what if my patient, the patient we're taking care of, has congestive heart failure? They already have a condition where their fluid level in their body is already high. I can overhydrate them. It would be the same concept of saying, here, heart CHF patient who can't have any fluids, here, have a whole pitcher of water. You know, you guys do know that. Did I mention that to you guys before? Desmond mentioned it to you? Especially those that don't work in a hospital setting. I know when you're in there, you want to be nice and accepting by your patients. When your patient asks, hey, can you get me some water? I would love to. But what if that patient has congestive heart failure, and the second you give them that pitcher or even that little glass of water, you push their fluid status overboard, and now they're in congestive heart failure. So I always say, sorry to my folks in nursing, but I'll press the button and I'll ask for you, hey, can Mr. So-and-so have some water? When you say that, you're going to see their expression go, oh, they know what the answer is. They've been asking the nursing staff all day for it. They just see a different face, you, and think, let me see if I can sucker this person into getting me some water. So I will never get a patient water unless the nurse or the nursing staff says it's okay. And if they're busy and I know exactly where I'll grab it, no problem. It'll take me a couple of seconds to grab it and help you out and be part of the team. But I'm not going to go just myself and think, oh yeah, anybody can get some extra water. Anyways, how did I get there? Overhydration of secretions. Same concept. Bronchospasm. Bland aerosols can be irritating to the airway for some patients. Especially patients with reactive airway disease. Airways that are already very sensitive. Lack of a better word, twitchy. You know, your asthmatic patient may have some twitchy, very sensitive airways. You start giving this to them, you could put them in bronchospasm. And bronchospasm is when the bronchi constrict, and then we hear wheezing. Noise. These things can be noisy. Not so much where we would notice and think it's a bad thing, but if we have these things set up and maybe it's attached to an enclosure, like with the neonatal patient, inside that enclosure it can be very loud. So even though it might not be loud to us just in the room, but the second you put that thing over the child's head, all that flow, all that gas going through may be very noisy to them. And you wonder why this child is so fussy, so agitated and irritated, because they can't sleep. They have this roaring in their face and in their ears. And we wonder why they are fussy and can't sleep, and it's all my fault. I put all this noise inside their chamber. All right, so last thing here specific about just bland aerosol in general for sputum induction. useful, cost-effective, safe method for diagnosing tuberculosis, pneumocystis pneumonia, or now known as pneumocystis jirovecii or pneumocystis carinii, as well as lung cancer. So, to go back, TB, certain pneumonias, and lung cancer, where you need a sputum specimen to be able to diagnose those conditions. Tuberculosis, certain pneumonias, and lung cancer to be able to diagnose, where you have to actually induce a sputum. So this involves a short-term application of very high dense saline, hypertonic saline. Now, depending on what we're using could vary, but obviously 10% would be a stronger salt concentration than say 3%. And even know what the concentration is of normal saline? 50? Oh, much less. 0.9% is normal saline. When we use normal saline with our nebulizers, generally little pink little vials, that's 0.9% sodium chloride, salt solution. But this is obviously much more concentrated concentrations of salt, hence the word higher levels of salt, hypertonic saline. We can use those. Those can really be irritating to the airway, which helps to kind of loosen up mucus and elicit a cough for our patient. But just as a reminder, a good sputum sample must come from the lungs, not the oral cavity, not the sinuses. We need sputum from the lungs. Some hospital protocols, and again, I always say, when we're in a certain hospital, we got to do what their policy or protocol states. In some, they could be so specific because they want to make sure there's no oral secretions in there that you have the patient brush their teeth and tongue really well before we do sputum induction. So knowing we're going in to do sputum induction, okay, go ahead, brush your teeth really good, brush your tongue really good, making sure there's no bacteria, no contaminants there. So when they do bring up, after our therapy, they do bring up some mucus, it's really clean mucus, lack of a better word, clean mucus from their lungs, that then the lab could then analyze. And again, not to sound disgusting, you'll hear patients really clear their sinuses, like, all right, that's not where we're trying to get this from. I need you to cough and bring that congestion up from your lungs, from your chest. Questions? All right. So no questions, really? I got a bunch of questions for you guys. How about that? Change it up once. All right, first question. A typical HME can provide approximately what percentage of body humidity? Is that 25 to 35, 45 to 60, 70 to 90, or 90 to 100%? 70 to 90. 70 to 90. This one is C, 70 to 90% of body humidity. And like I said, that's your typical HME. Saving this conversation for another day, so not to confuse you, there is such a thing known as an active HME, where you actively add moisture to it, and then guess what you can get? 44. You can get 44 with the active HME. You don't see those very often. I was curious. I looked up the cost for an active HME versus standard heated humidification. Active HMEs are even more expensive. So hence the reason you don't see them until costs come down, as opposed to your typical standard run-of-the-mill HMEs that maybe cost 50 cents or $1 or $2. All right, so this one was C. Next question. Which best describes how an ultrasonic nebulizer works? Is it pneumatically powered, electrically powered, pump powered, steam powered, powered by a cotton gin? I don't know. I think I know the wrong answer. This one's electric. This one's electrically powered. Electrically powered. If I reword this question and say large volume nebulizer, what would be the right answer? That would be pneumatic. Pneumatically powered. Everybody okay with that one? All right, remember how I said on Monday's test there's potential for pictures? Pictures like an airway device, an ET. I'm not going to give you an ET tube if I know everybody would get that right, but maybe I point to a certain point of the ET tube.
Well, why can't you just give us that one then?
You can give it all away. Or one of those alternative airways, I give you one of those pictures. But what if I give you something like this? Okay? Name the following device used to deliver bland aerosol therapy. Is this a TP, straight collar, face tent aerosol mask, or is this a non-rebreather? This is an aerosol mask. This is an aerosol mask. Everybody snap a picture if you wanted it. I'm clicking. Next. You know, this stuff, I know I came across these on the internet, Google search aerosol mask and come across. But Friday, when you have this stuff in front of you, I think you better have a picture of yourself wearing it. That's just my thought, my opinion. All right, what's this one? That's a face tent. That's a face tent. Why would you choose a face tent over some of the others? Beaten nose, fractured nose, some sort of facial trauma, something where an aerosol mask would be too uncomfortable for them to wear. Do you think patients present sometimes with nasal bleeding, epistaxis? And you would think if they come to the hospital with that, how long has their nose been bleeding at home before they finally said, I gotta be seen because my nosebleed won't stop. Just imagine how many tissues they've gone through before they finally decide to show up at the hospital. They could put a device actually inside the patient's nose, inflate up a balloon to stop the bleeding. And then you have this big, massive thing sticking out of their face. Aerosol mask wouldn't work, right? But they need something. Nasal cannula, yeah. Good luck getting that prong up there. Maybe something like this could be set up. All right, what's this one? This is a T-piece. This is a T-piece. Remember, a T-piece can be connected to an endotracheal tube like pictured here, or it could be directly connected to a trach. And notice I said directly connected to a trach. And I think my last one. You're good with all these pictures on the test? Okay. Okay. There's the first 5 questions, or 4 questions, whatever it was. Trach collar. I mean, you guys know on paper the pictures are going to be black and white. I know that sometimes they can be a little challenging to see, but I'm never opposed to you raising your hand and asking me maybe to describe it. I'm not going to tell you what it is, but maybe, John, is that directly connected to the trach or not? I'll tell you in this one, it's not directly connected to the trach, but it's around it. But trust me, no. When I do include pictures, I print it out and I look and say, yeah, that picture sucks, and I got to find another one. And hopefully you'll be able to see it okay on the printed copy. But if there's ever a doubt or question, raise your hand and I'll come to you and I'll try to describe in so many words what it is. All right, any questions? All right, don't forget about this Friday's lab, and good luck on the test on Monday. Good luck on the test on Monday. So I have 11 o'clock right now. Can we start a little early? Can we start a little early, say 11:45? 11:45. I do know at 11 o'clock, Louis Seafood and Wings food truck is downstairs, if anybody is curious. So I know sometimes those things get so big in line, so it might need a little bit of more time. I think one time I gave you 30 minutes, and you took 30 minutes to finally get your food. So if anybody's curious or wants that, I was told they're supposed to be down there. But if not, we'll start back at 11:45. 11:45. And you get to see what new formulas we talked about today.